is Sawan Jadav. He is a biology and chemistry major. He comes to us from India. Imagine that. He is that small, underpopulated nation in Southern Asia. And he wants to go to medical school after he finishes here at King. And he is going to talk to us today about some new technology on the horizon for MRI. So let's welcome.
This is what nervous feels like. My talk is about MRI, and okay, I'm going to talk about history of MRI, some controversy related to the findings of MRI and the Nobel Prize, and so a small section on how MRI actually works, and my hypothesis, paper 1, paper 2, restating hypothesis, and then bashing can begin. Nikola Tesla discovered the phenomenon of rotational magnetic field in year 1882. This was one of his many achievements. So physics people know the giant. In 1937, a professor named Isidore Rabi did some of the research at Columbia. He observed the quantum phenomena dubbed nuclear magnetic resonance. And nuclear magnetic resonance is the same, it's like an older name for MRI, magnetic resonance imaging. Professor Rabi built a molecular beam apparatus in Columbia in year 1931. He employed weak magnetic field instead of strong one, which they hoped to detect nuclear spin on sodium, and they did eventually. So all the way from 31 to 37, they've been working on this nuclear imaging, and finally in year 37, a bunch of them were able to successfully measure the magnetic moment of lithium isotope. So people who have already taken organic or who are about to take organic, this is the organic part of nuclear magnetic resonance. That technique is used to identify the compounds, and you'll see it's amazing. By the way, in '94 he also got the Nobel Prize for this. Now we're going to jump from the physics side of it into medicine. Dr. Raymond Damadian was a physician who worked at Brooklyn's Downstate Medical Center, and he discovered that the hydrogen signals in cancerous tissues were different than the tissues, like the non-cancerous tissues. He was doing this in petri dish at the time. In 1973, this is another scientist, Paul Lauterbach, who a chemist and an NMR pioneer. The pioneer part is still under controversy, but he worked at State University of New York, and he submitted the first paper, which was rejected by Nature. And eventually, he wins the Nobel Prize later. So, if you submit a paper to a good journal and it gets rejected, you're in good company. Mansfield developed a mathematical model. So Damadian already has used this technique to look at living cells before, but Mansfield comes in and improves it. And this is where the controversy kicks in. This is just the Nobel Prize visit to White. Let's get back. Damadian says that I'm quoting Damadian now, if I had not been born, would MRI have existed? I don't think so. If Lauterbach had not been born, I would have gotten there eventually. So Damadian thinks that he should be given all the credit for using NMR on any sort of living, like live tissue. So the jump from taking this physicsy phenomena into medicine was his idea, and some would argue it was. But as I've told you earlier, Dr. Lauterbach and Mansfield were given Nobel Prize, and Damadian wasn't. So this was the article, and I'm just going to read the section of the article. The issue had been the subject of dispute between Dr. Damadian and Dr. Lauterbach, and had been known for years in academic circles, with some fearing that Nobel Committee would steer clear of magnetic resonance imaging altogether because of Sweden's supposed distaste for controversial discoveries. Dr. Lauterbach is not in good health, and committee may have decided that this prize, which cannot be given posthumously, that was the funniest one, needed to be awarded for discovery now or never. A Nobel Prize does not award discoveries to, like awards to people who had died. So they had to decide that whether they should award the Nobel Prize for NMR at that time, or they should just forget it forever. So I'm done with the history part. Now I'm going to try to explain, once again, I'm going to try to explain how NMR actually works. NMR or MRI, it's the same phenomenon. Protons align with high magnetic field, and then radio frequency puts these protons out of alignment of some angle. If I had a marker, Sawan. Thank you, Dr. Gilman. I'm already nervous here.
His heart rate wasn't going fast enough.
I'm going to try to have put a cartoon diagram of what I'm trying to explain. Imagine this is I have to keep some space here. Imagine this is your liver, and your intestines are right here somewhere, other organs, and all the hydrogens in this organ are just, let's call it organ X instead of liver. They're all aligned this way. And the other hydrogens might be aligned other direction. There's one other organ here aligned different. When you pulse them with high radio frequency, they all change their direction to, let's say, this side. So all of this would change the direction, all of them. And when the pulses stop, it goes back. And this going back of the proton spin would give us the NMR results. So you zap the whole system. I mean, you're not electrocuting the system. Zapping the proton spin, it goes to a different angle and it comes back. The difference in timing, this hydrogen might take a little longer than this one's, and that gives you the difference in the MR kinetic. Here's my hypothesis. Improvements in magnetic resonance imaging technology would lead to better diagnostic capabilities in clinical setting. This is my first paper, accuracy of 3 Tesla magnetic resonance imaging for diagnosis of intra-articular knee injury in children and teenagers. MRI is a commonly used tool for diagnosis of knee injury. And MRI has advanced. Now, they also have 7 Tesla MRIs, but it's only used in research areas. They haven't been implemented into clinical settings yet. In most cases, 3 Tesla is the highest magnetic field in clinical settings. And 3 Tesla has shown to have good results in adults. And people at Cleveland Clinic wanted to see if this results can be replicated in younger patient knees problem. This was the surprising part in the paper. A CDC report on the incidence of non-fatal sports and recreation-related injuries showed that majority of those presenting to emergency department were under age of 19. I thought that with all this professional sports going on and college level athletes, that would be a major group of patients that would come into emergency departments with knee injury or ankle injury. But according to CDC report, it's people under the age of 19. A meta-analysis of 49 epidemiological sports injury studies from 66 to 2006 showed that the lower extremity, more specifically, the knee and ankle are the most common injured sites in the age group I mentioned before. That was under 19, especially 10 to 14. So the, knee injury in adolescent population is a common problem. And this group wanted to see if they could replicate the advances of 3 Tesla MRI onto in adults that they have seen before into kids population. The aim was to evaluate 3 Tesla MRI for diagnosis of intra-articular knee pathologies in pediatric and adolescent patient population. They used electronic medical records of patients under age 19 at their facility who had 3 Tesla MRI studies of knee followed by an arthroscopy from September 2008 to April 2011. They took the interpretation of radiologists and the staff surgeon, and they were examined with and the dictation notes and the focus on meniscus and ACL injuries. Now I'm going to show you some. They were divided. The injuries were divided into 3 major parts: ACL tear, the lateral meniscus tear, and medial meniscus tear. I'm just going to show you some structures now. The arrows are pointing towards the ACL. This is a normal looking ACL, like an MRI image of a normal ACL. This is MRI of a torn ACL. Some of the structures in this picture are going to be important for the results in the study. The lateral meniscus, the medial meniscus, and ACL are the 3 major injuries that they are going to classify in this study. This is showing the top-down view of the knee, and your patella would be right here. So imagine if a patient is standing in front of you and you're looking from the top in the knee. Anterior horn, body, and the posterior horn. Although this is, they're also going to talk about the lateral meniscus of the anterior mid-body and the posterior horn. And this picture was about the medial meniscus. 116 patients met the criteria. 3 patients had bilateral involvement, so total of 119 knees were studied. 64 male patients, 2 of those had both knees under study, so total of 66 male knees were studied. 52 female patients. One of them had bilateral involvement. That means total of 50. That should say 53. My bad. Total of 53 female knees were studied. It's just 64 right knees and 55 left knees, but it doesn't matter for the study. The average patient age was 16. Average age at the time of surgery was 16.2 years. This table shows the operative, the very right part is what they found during operation. And the MSKR, this is musculoskeletal radiologist, I'm just going to call it radiologist, had predicted after looking at the MRI that there would be 41 tears at MMT, but there were actually 42. So this is the data that shows how many radiologists and staff surgeon had predicted by looking at the MRI and what was the actual tear when they went in when they took the patient in the operation room. This is just the same injuries divided into posterior horn, mid-body, and the anterior horn. The picture I showed before of where the injury is located on each part. This table is what the radiologist found in this particular study. For medial meniscus injury, the sensitivity was 81%, the specificity was 91.9%. Sensitivity is just, the easiest way to explain it is true positive. So if they predicted something, if they predicted a tear and it was an actual injury, then it would be sensitive. And if they predicted that definitely wasn't going to be a tear and it wasn't, then it's going to be specificity. These are the operating surgeon's, staff surgeon's interpretation after looking at the MRI. And in both interpretations, you guys can see that ACL tear was the probability of predicting the tear was higher in ACL by both radiologist and staff surgeon's interpretation. These are some of the specificity and sensitivity data from previous studies using like less than 3 Tesla magnetic strength. Some of them are just 0.5 Tesla. Most of them are 1.5 Tesla studies. And if you look at the sensitivity, again, this portion right here, you'll see that some of them are in mid 80s, high 70s, high 90s. And this is a similar study, just they're looking at ACL tears in this one, the sensitivity and specificity. This is results of many different studies in which they are actually using a 3 Tesla magnet, and the sensitivity and specificity increases a little bit in all regions, especially in the ACL. Conclusion of this first study, the accuracy of predicting ACL tear has increased, while they were not able to predict the other injuries any better than using 1.5 Tesla magnetic strength. Since 3 Tesla MRI was still less sensitive in meniscus injuries in young patients, 3 Tesla more accurate for medial than lateral. So it was a marginal improvement in medial medial tear prediction, and not so much in the lateral tear prediction. I'm going to look at a second paper in this, and this authors are looking at a 3 Tesla MRI machine along with 1.5 Tesla magnetic resonance imaging in newly diagnosed breast cancer patients. Patients with newly diagnosed breast cancer may benefit from preoperative breast MRI to search for additional mammographically occult malignancies. That means the cancer cells that are hard to find, they're hidden, can be found with better MRI techniques before going to surgery. The aim of this study was to compare 3 Tesla and 1.5 Tesla magnetic resonance imaging system in newly diagnosed breast cancer patients. 98 consecutively 1.5 Tesla MRI examinations between July 1st of 2009 and December 19th of 2009. They were taken. So this many patients came to their facility before December 19th, and they took 147 consecutive patients with the 3 Tesla imaging. So on December 19th, they changed their system from 1.5 Tesla to a 3.0 Tesla MRI machine. Out of 147 patients in the newer MRI machine, 11 patients didn't have the pre-chemotherapeutic data, so they just went ahead and had chemotherapy somewhere else, and they didn't have data for some reason. So they had to exclude those 11 patients from the 3 Tesla MRI machine data. So it left them with 136 patients. This table shows that there was not much difference in the both groups. The median age was 56 in 1.5 Tesla, while in 3 Tesla it was 55. The family history of breast cancer was also very similar. There was no statistical significance difference between the two groups. That histology also was similar, and this table is just to show that although there were two different sets of population, all the factors were similar, or one different enough. This table shows the suspicious lesions that they found with using both kinds of MRI machine. they found 98 suspicious lesions in patients when they took the images from 1.5 Tesla machine, and they found 206 from patient group of 3 Tesla machine. Although the number of patients in 3 Tesla was higher, so the average number per image was higher in 3 Tesla anyway. So although the number of patients was higher in 3 Tesla, then the average number of suspicious lesions were higher in 3 Tesla group per patient. And the last line here shows how many of them were biopsy. 9 of them were recommended, but 80 of them were biopsy. 88 of 98 was 90% was biopsy, while 198 lesions were biopsy. That's 96% of the suspicious lesions found. This is the patient outcome after doing the biopsy. If you guys will focus on the third row here, malignant, they found 14 out of 98 biopsies that did were malignant in a 1.5 Tesla group patient, but 22 of them were malignant in 3 Tesla. But if you look at the percentage, 16% were, 14 out of 14 and 33 of 136, that means 24%. So with this machine, they only found 14% of biopsies to be malignant, which had cancer. But in the 3 Tesla group, 24% of the biopsies, they suspected lesions they did biopsy was cancerous. And the p-value is 0.07, although it's not statistically significant, but it shows the trend that the 3 Tesla machine was better in recognizing more lesions. Here are just images for reference. These are not part of the results. This just shows some images of 1.5 Tesla MRI machine. These ones are the 3 Tesla. If you guys can tell the difference, like the 3 Tesla is much more sharper than 1.5 Tesla images, but it's hard to see on the bigger screen. The conclusion of the second study is the 3 Tesla MRI machine detected more additional malignancies in patients with newly diagnosed breast cancer and yielded a higher PPV of biopsies performed with a 3 Tesla system. My hypothesis restated, improvements in MRI, improvements in magnetic resonance imaging technology would lead to better diagnosis capabilities in some cases. So when I started my research, I thought better MRI is going to be better results for all cases. Well, that's not true. As we saw in the knee study, only ACL dev was predicted better than 1.5 Tesla machines. In other cases, it wasn't. And I found in my research that there are other cases in which, not just breast or breast diagnosis or the knee one. There are many different cases in which the 3 Tesla is not helpful. So it's not worth putting more money or more effort in. So in some cases it's helpful, in some cases it's not. Here are my references. Questions? Yes, Dr. Bliss.
What type of contrast were they using, or what sort of parameters were they using in this? Because, I mean, you can do MR with or without contrast. You can do T1 or T2, and that makes a difference as to what you're looking at and the level of detail that you can get. So did they also compare the protocols?
Yes, they did. In the knee study, they didn't have any contrast.
Okay.
But in the breast cancer study, they used, if you don't mind, just give me a second here. They used T1 study. They gave them the injection of 0.1 millimolar per liter of gadapentate dimaglumin manufactured by Magnavist company. That was 0.1 millimolar per liter per kilogram of body weight in both cases, in both 1.5 and 3 Tesla.
So, and they did that in the MR as well. So when they were looking at previous, so if you go back to table 1, study 1, I think. Is this the breast cancer one?
Yes, ma'am.
I need table 1 in the study, first study, the knees. I think that's probably. Oh, actually, that one did it. Actually, you can go, yeah, this. So for example, in these studies, this paper is saying, compared to all of these studies, which was not done at a 3 Tesla, they're comparing their 3 Tesla results to all of these studies.
Yes.
So did it mention in the materials and methods whether they were following the same imaging protocol, except it was just a 3 Tesla?
Yeah, they did mention it, that they had a similar protocol.
Okay.
So I'm assuming they didn't do anything like contrast or different, like completely different. There were similar protocols for knee. That's what I got from the paper.
Okay.
They didn't, then the paper on the knee didn't talk about any kind of contrast at all. Any question? Yes, Robert?
In these studies, did they ever compare the same biopsy area with both instruments?
No, that was one of the shortfalls in both of the studies, that they didn't compare. And the group that did breast cancer studies from Yale Medical School, they strongly recommended this. The studies like this should have been done using the same patient population. Like the same patient, just take n equals to 100 or 50 or whatever, just use both machines. But that didn't happen.
Okay.
I tried to find papers in which they had the same patient population, but I didn't have that confirmed sample. I mean, unless I started paying for it, I might find 1 or 2 papers.
Put in a proposal for NIH. Do it.
Just trying to write a personal statement and study for NCAT is enough. I'm not, that's my limit. That's all the horsepower I've got. I'm not going to write an NIH study. That's public fitness stuff. He's powerful enough to do
I'm
that.
pretty sure he was kidding though.
I just want to make sure that it's got any possibility. I just want to put it out there. That's not for me. I'm not built for that. Just saying. I know he was kidding. Any other questions?